Okay, so I guess I'll just get started. So today is my noon report presented by yours truly. And I don't have any warm up questions. We're just going to get straight into it. The chief complaint is going to be altered mental status, our favorite. And for the HPI, we have a 62-year-old man who was found to be unresponsive by his home health aide this morning at 9 a.m. He was previously at his baseline alert and oriented times 3 the day before. And we called his sister, who states that he's had multiple admissions for altered mental status since October 2018. And when we reviewed the chart, he has had an admission about once every 6 months for altered mental status, secondary to hypoglycemia versus sepsis from UTI. But over the past month alone, he's had 3+ admissions for altered mental status. His most recent admission was last week, and he was discharged with a PICC line and a 7-day course of meropenem. And I just wanted to stop right there and just ask, what are some key things that we can guess about this patient just from this HPI alone? Obviously, we have pretty limited information, but I'm wondering what stood out to you guys about this HPI and what things you might be able to infer about his past medical history and things contributing to his presentation today.
Kind of feel
If
free
he
to.
has hypoglycemia, does he have diabetes?
Yeah, I think that's a good one. Yeah. History of many courses of antibiotics, chronically ill man, probably diabetes. Maybe has indwelling Foley. Yeah, that was perfect. That's basically everything that I put. Chronically ill. He's got recurrent UTIs, which would be uncommon in a man. So maybe this suggests he has an indwelling catheter. He must have cultures showing ESBL if he was recently discharged on meropenem. Hypoglycemia, maybe he's got severe cirrhosis, or he's got diabetes and he's taking too much insulin, or maybe he has a new AKI and he's taking insulin still, and that's causing hypoglycemia. And then the fact that his rate of problems are accelerating does suggest that either something is worsening at home, or the prior diagnoses that he's had may be incorrect, and maybe something else is going on. And yeah, questionable bad home health care as well. So let's take a look at his past medical history. So he is a wheelchair user. He has a left BKA, secondary to lower extremity osteomyelitis. He's got diabetes, CKD, diabetic neuropathy with a chronic indwelling Foley, like we guessed. He's got recurrent UTIs and then a whole host of chronic medical conditions. For allergies, he's had a rash to aspirin in the past, and he's had an overdose on Dilaudid before, which required Narcan for reversal. And then he's on a whole host of medications, including Claritin, Docusate, aripiprazole, gabapentin, ferrous sulfate, escitalopram, meropenem, which he finished 2 days prior to admission. He's got tramadol, imipramine, Bumex, baclofen, pravastatin, metoprolol, omeprazole, and insulin. Got a little polypharm going on, exactly. And social history, he's not a smoker, not drinking. Family history, non-contributory. And then for the med students in the chat, I just wanted to go over his insulin regimen right here, which is kind of interesting. He's got 40 units at night and 2 units with meals. Typically we do the basal bolus regimen, which would generally be something where we split 50% of the insulin to bolus and 50% to the basal insulin. So for somebody like him, you would expect 25 units of glargine at night and then like 8 units with each meal. The fact that he's only on 2 units with each meal, it makes me wonder if his previous episodes of hypoglycemia, they thought he was getting too much of the bolus insulin. So maybe that's why they have him preferentially on just more basal insulin rather than bolus insulin. Okay, so moving on, we'll go straight into the problem representation. But hold on a minute. Objection. Why do we even do problem representations? Isn't this just a big waste of time? Obviously, we do this in every noon report, so I thought I'd look a little bit into why we do problem representations every time. And it's this whole thing about diagnostic reasoning, where we come up with our problem representation, and we use that to build our repository of illness scripts. And over time, as we see more and more cases and collect more data, we're able to refine our problem representation, come up with better illness scripts, and then be able to choose them more quickly to come up with a faster treatment and decision about what's going on with a patient. And then just from a bird's eye view, clinical reasoning is a process by which clinicians collect, process, and interpret patient information. It helps the learner develop memory schemes for representing and relating clinical problems, and repeated exposures to these cases enhance acquisition and storage of knowledge and long-term memory. There's two types of clinical reasoning, which I'm sure you've heard of before, but really we got the type 1, which is the very fast type of thinking. It's used by experts most of the time because they have really good pattern recognition and could just immediately recognize an illness script right off the bat. And then the type 2 thinking, which is slower, deliberate, and more reliable. And typically when we're doing our problem representations, it's kind of this type 2 thinking. And the whole goal is to improve the type 2 thinking until it gets like this type 1 fast processing. The big problem is a lot of us, a lot of times it's easier to just skip to the type 1 without going through this slower, more deliberate process. And that's called the cognitive miser function, which I had to look up. But basically it describes the ability and tendency of the human brain to problem solve in the most simple and straightforward ways rather than using more sophisticated and effort-intensive ways. But really, I think, doing this practice of problem representations can be cumbersome at times, but it is really important for helping us develop that type 1 kind of thinking. And then making a problem representation, obviously, we translate things into precise medical terms, use semantic qualifiers, we discuss the who, what, and when, and then it allows experienced clinicians to use pattern recognition and allows learners to develop their reasoning skills. We always like to keep it simple. And so my big thing with, at least the way I prefer doing the problem representations is, for somebody like this patient who's got a lot of things going on, it can be difficult to choose which things are actually relevant. But I like to just kind of pick one or two things and kind of anchor on those things to choose one specific problem representation that triggers a specific illness script. So anyways, back to the case, I am wondering what problem representations you guys might come up with for somebody like this. And here's a couple of little pointers, of how to keep it really short, and then, dropping your anchor on something specific and refining the problem representation as more data comes back. So what would you guys say for the problem representation for this patient? You just type it in the chat. I don't know if my chat's running.
All right. We're going to say a chronically ill, middle-aged man with diabetes and indwelling Foley presents recurrently with AMS.
Yeah, I like that a lot. That's actually a perfect one. I kind of came up with three different ones, and that one that you just said kind of matches up some of the ones I have. And then here's middle-aged man with complicated past medical history and frequent admissions presenting with acute onset altered mental status. I would add polypharm. See, yeah, that's the thing. That's deliberately why, for this specific patient, I felt like there's so many different things. There's so many different ways you could come up with a problem representation. So here's some that I came up with. So you have elderly man with chronic indwelling Foley and frequent UTIs presenting with acute encephalopathy. So that triggers one particular illness script. You could have elderly man with significant polypharmacy presenting with recurrent episodes of encephalopathy. So that in this one, you're more pinning it on the medications, obviously. Or you could have elderly diabetic man with prior episodes of hypoglycemia presenting with acute encephalopathy. And then I kind of wanted to go briefly into this discussion. Is the patient middle-aged or elderly? Because I feel like in so many of these noon reports, I'm trying to struggle to figure out what to call the person. First of all, yeah, so what if they were 59 years old? I feel like most people would say middle-aged, but what if they were 64, or what if they were 65? Like, are they middle-aged when they're 64 and then suddenly they're 65? And who is your attending? Yeah. I did hear somebody say in one of the most recent noon reports that you should have whatever your attending is and add 20 years, and that's your cutoff for elderly. But why does it even matter, first of all, and is this just more mental gymnastics? So first of all, age is just a number, and I think in general, middle-aged to elderly should primarily be determined based on the patient's functional status, for example, frailty. But I do think it is useful in our problem representations because it helps to frame to other clinicians how well the patient will be expected to respond to treatment and improve. And geriatric patients respond differently to younger patients to pharmacotherapy, and they're more prone to adverse effects. This man is medically elderly, and I agree. So that's kind of why I chose to call him elderly. Just a little bit of echoing from GenMed 5. So, and then I kind of looked.
Sometimes it really does matter. I have to say, there are some disease entities where there's sharp cutoff, you know. In rheumatology, GCA generally doesn't happen people below 50. You know, you have to have pain start. We had ankylosing spondylitis last week. It really needs to start before age 40 or 45. There's some types of things you might consider where the age really does make difference. Mm-hmm. But I don't know about the definition of middle age versus elderly as words.
Right. Yeah. Thanks, Dr. Wise. So I looked into a lot of different trials. So most randomized control trials do put the cutoff at 65. The UN puts it at 65. But then if you go into the SPRINT trial, you know, they said age greater than 75 was a risk factor. And then this paper, Caterino, they found that being age over 70 in trauma patients was independently associated with higher risk of mortality. Looking at the World Health Organization in Africa, it's 55 is their cutoff for elderly age. And then the Society of Geriatric Oncology says greater than 70 years. And then there's just a whole bunch of other studies that use different cutoffs. And basically, what we're seeing is that a lot of these studies are suggesting to raise the cutoff to, you know, age 70 or 75. But again, I think middle-aged to elderly, again, should be determined on how functional the patient is. So even though this guy's only 62, I would probably classify him as elderly just given all his medical complications. All right, so let's go on to the physical exam. So for his temperature, he's afebrile. His blood pressure is 156/91. His heart rate's 78, respiratory rate 12, and O2 sat is 96%. For his physical exam, he's an elderly, obese man in acute distress. He's normocephalic, atraumatic, no JVD. His pupils are 2 millimeters and fixed. They're not reactive to light. His heart is regular rate and no murmurs. His lungs are diminished bilaterally. He's got a loud, productive cough and increased work of breathing. His abdomen is soft, non-tender, non-distended. He's got paradoxical abdominal breathing, so just kind of really with increased work of breathing. He's got a Foley in place, no peripheral edema, left below the knee amputation. He's got an ulcer on his right lateral malleolus. It's open and draining a small amount of purulent fluid. He's obtunded. He does not arouse to voice. His GCS is 7 to 8. He's got decreased movement of his left arm compared to his right arm, and he does not blink to threat. I'm wondering what people think about this physical exam here. Anything that particularly stands out to anybody? The pupils. Yes. And then for the med students in the chat, intubation is usually, this is a question I have, intubation is usually indicated for GCS below what number? Stephanie says 8. Nice. Exactly. 8 or lower. So this guy was, his GCS was 7 to 8. He didn't end up actually getting intubated. And then I do want to also kind of get your opinion on what are likely sources of infection in this patient if you think he's infected. And the other question is this patient septic? Would you guys say that this person is septic? Foley ulcer. No and no. Do you SOFA? Exactly. UTI versus skin versus CNS. Nice. Yes, he's got the line as well. He's got the pick line. Heart rate, respiratory rate normal. What is white count? His white, he does have a leukocytosis. It's like 12.9. We don't have a lactic back yet.
Hey, Conan, quick question.
Uh-huh.
In his massive past medical history, does he have a history of a stroke or anything? I'm just curious about like why he's moving one side less than the other. Are we, needing to rule out stroke as well as we're going through this infection thought?
He does not have a history of a stroke, but he does have a history of this like left arm palsy per his sister when we called her.
Gotcha. Yeah, I was just thinking about, because sometimes you can think if someone's had a prior stroke, for example, and maybe they had, some recovered movement, they've been like not able to use their left arm, then they have some recovery. You can think about recrudescence when you have something that stresses them out, then they can act like they have that deficit again. So that was something else I was thinking about versus this, a new stroke or something that we want to rule out too.
Yeah. All right. And then Narcan, we will get to the Narcan in a bit. But he did get Narcan. We'll go into that in a bit. So what are clinical scoring tools we can use to help identify sepsis? You guys have already talked about it. SIRS and QSOFA. What are the components of SIRS and QSOFA? We got, here, you guys know it, so we'll just skip past that. So what if the patient was hypotensive? Would he then be septic? And I would argue that this person, based on his QSOFA score, you would not say he's septic. But given how sick he was, I don't think anybody would be faulted for treating him as sepsis and all the particularly like different ways he could be infected. Still no if he's hypotensive? It's a predictive model for need for higher level care. So I would say if he was hypotensive, I would, it's a clinical diagnosis. I think if he was hypotensive, I would argue that he would be more on the lines of sepsis. But if he wasn't hypotensive and he had a fever and a leukocytosis, would he be septic? I would say no, based on Sepsis 3, because in Sepsis 3 guidelines that were released in 2016, we're actually no longer supposed to be using SIRS criteria because it's very non-specific. And they do want us to be using QSOFA. And so I still see SIRS being used a lot. And it seems like people haven't really accepted Sepsis 3 at this point. And I'll go into this a little bit more later, but definitely, like if we're following Sepsis 3 strictly, then even if he meets the SIRS criteria, like we're not supposed to be using that anymore.
Conan?
Yep.
Sorry, just kind of to intercept real quick. I think it, from my understanding, and others can correct me if I'm wrong, but I think it has to do with billing currently. I think Medicare is going to be transitioning their billing, I want to say, but currently it's still the bill for sepsis. Like we bill for sepsis, they haven't integrated QSOFA, I think, in their billing, from my understanding.
Right. I mean, if he's QSOFA positive and he has a suspected infection, I would put sepsis. I don't put just like QSOFA positive or whatever. But I also don't put SIRS positive. But I don't know how you guys feel about that because, I mean, a lot of people are SIRS positive, but it's not necessarily saying anything, you know? Okay, and this last question really is talking about sepsis versus severe sepsis. Based on Sepsis 3 criteria, there's no such thing as severe sepsis anymore, and you're only supposed to call it sepsis. So this is something I'll go over a little bit later as well. So anyways, for his physical exam, what workup do you want? Would you give him fluids, and would you give him antibiotics? If so, which ones? Critically ill would probably antibiose, looking at previous susceptibilities. Blood cultures. Would you just get the blood cultures, or would you get the blood cultures and then give antibiotics as well? He finished the meropenem 2 days ago. Pan culture, chest x-ray. Okay, I like it. All right. So I'll let you guys keep typing in what you would like to get, and then we will talk about altered mental status, our favorite discussion that happens every other noon report. And obviously, you guys know my favorite mnemonic. You've got all of these ones: AEIO tips, AEIU whatever tips, move stupid, go times, no moist, no. This is the best one. It's my noon report, so I get to choose which mnemonic we use. And this is the best one. Let's go straight into the clinical problem solvers algorithm. And you can see they use MIST, but then I add the O here because that adds hypoxia to the algorithm. But the first thing to note is that at the very top of their algorithm for altered mental status, there's several things that you need to treat before you diagnose. Okay, so don't proceed before treating these. So dextrose, so for hypoglycemia, oxygen, make sure they're not hypoxic, give them Narcan, and then give them thiamine. So these are treatments before diagnosis that you should give if you have high suspicion and you're not really sure what's going on yet. After you go through that, then you can go into the moist mnemonic. And obviously, this is like a really great diagram that I really like. It shows you that hyper or hyponatremia can both cause altered mental status, high BUN, creatinine, any changes in sugars, calcium, and then you got hypercarbia, hypoxia. You got these endocrine abnormalities. And then other causes very frequently seen are urinary retention and constipation. For infection, you want to do your whole infectious workup like you guys ordered: chest x-ray, UA, blood cultures. Consider an LP. Structure, so S, I added structure, stroke, and seizures to this one. So you get a CT scan, and if you have a higher suspicion for seizures, you give EEG. And then toxins, obviously you get a urine drug screen, and then there's different types of toxins that could cause it. So remember, don't proceed, and then do the moist mnemonic after that. And then you can make a cool dot phrase for this, and you can see I've got my nice little mnemonic there, and it gives you a cool little diagram of things you should consider getting in these patients. And I know this mnemonic makes people uncomfortable, but sometimes we got to lean into the discomfort a little bit. So let's see, what workup do you want? So he got the don't treatment. So he got a point of care glucose, which was 164. His O2 sat was 96%. Naloxone was given, no response. IV thiamine was given. And then in the ED, they gave him 1 liter of fluids and Zosyn times 1. So for his workup, he got a CBC, BMP. I'll just load these all up for you guys. All right, here's his workup. So wondering what people think about this workup. And he did end up getting that CT head due to concern for a stroke. So what stands out to you about this workup, and what do you think your leading diagnosis would be at this point in time? Could think about EEG, probably not top of my differential, but non-convulsive seizure post-ictal given meropenem. Left upper extremity weakness could be Todd's paralysis and paresis. Could see lack of pupil reactivity with seizures. Would want to see what his previous urines look like. UA is a bit dirty. CT without contrast tells you nothing about a stroke unless it's hemorrhagic. Yes, that's correct. So leading diagnosis is polypharmacy versus UTI, and Dr. Lucatordo brought up potential seizure. Yeah, he's got an AKI. It's actually the baseline is 2.3, so his creatinine is pretty close to his baseline. And one thing with these patients with chronic Foleys is that a lot of times they will have, in this setting where he's so sick, you would obviously treat this, but a lot of times they could just have a urinalysis that looks like this, but if they're not having any symptoms, it actually could just be like asymptomatic colonization of their Foley. But obviously in this scenario, he's so sick, you would continue antibiotics for him. Yeah, that's what I'm saying. In him, he's altered, so you would treat it. Oh. And then I wanted to talk about his PCO2. So are you guys, can we tell if this is an acute hypercarbia or is this a chronic hypercarbia? And how can we tell that? pH is relatively corrected. Yeah, what would we expect? Yeah, you're guessing chronic. Okay. Whoops. I don't know what happened. Sorry, I gotta load this back up.
The PowerPoint was so fancy, it just couldn't take it.
Yeah. All right, so here I pulled up this acid base thing. And basically, we see that he's got a respiratory acidosis. For acute respiratory acidosis, we would expect for every 10 increase in the PCO2, his pH should drop by 0.08. So he's got about a 15 increase in the PCO2. So if it was acute, we would expect his pH to be 7.28. And really, we see that he's chronic. It only drops like 0.03 for every 10. So this is kind of expected for his level of chronic hypercarbia. And also for every 10 increase in the PCO2, his bicarb should go up by 4. So if we're saying he's going up by 15, it should go up by 6. So you can see his bicarb is 5 up from a normal bicarb. So that again shows more of a chronic hypercarbia. All right, so we talked about the top of our differential. We're considering UTI, polypharmacy, and seizures. So hospital day 1, he's treated for presumed sepsis from a UTI versus a skin and soft tissue infection of the right lateral malleolus. He's given Vanc and Zosyn, and all of his deliriogenic medications are being held. Then in hospital day 2, his white count downtrends from 12 to 9. He remains afebrile. He's lethargic, but he opens his eyes to voice and occasionally tracks movement. He does not follow commands. He moves his left arm less than his right arm still, with occasional jerking movements when aroused, and he's intermittently yelling, "Help me, God." All right, so I think at this point, we could potentially, we've got a lot more data, and we can have an updated problem representation leading to your highest differential diagnosis at this point. So is there anything you would want to update your problem representation with? Try and pick one problem representation that can trigger a specific illness script. We'll just wait for one person to respond, and then we'll see.
Can I throw out a question also to our attendings who are on here potentially? Because I think we've all been in, while people are thinking about their new problem representation, but I think we've all been in this situation where we have someone who comes in altered and we hold all their meds that could alter them. And I did this recently and precipitated like a baclofen withdrawal until, pharmacy was able to help me. Thankfully, very quickly, we, realized it. But at what level of baclofen, gabapentin, et cetera, do you guys think that you need to taper versus hold in this situation. Just curious if the attendings on here have anything to add.
You know, it really depends on the dose, right? And I don't know. 600 TID in an old person is definitely enough for gabapentin, and the baclofen 20 QID definitely enough for. So again, you could look it up, but he's got chronic renal disease, which makes it even worse. So I mean, either, I think I'd be worried about it. But I also think that those two drugs probably aren't. I don't know that they could account for this, but they could certainly be adding to it.
Yeah, I think the baclofen withdrawal and gabapentin are definitely like really good considerations for this patient as well. And in retrospect, I don't think he should have had all of them held on admission. But I think we were still like med recking him too, and it was like difficult to get all the med rec. So it actually wasn't even clear if he was taking that much. So anyways, I'll just do the updated problem representation because we didn't get anybody to bite. Yeah, I do remember like at the very end, I saw this patient back in September, so it was a long time ago, but we actually did find out it was 300 TID eventually for the gabapentin. Anyways, so here's the updated problem representation that I made. So we have an elderly man with recent meropenem, tramadol, and imipramine use presenting with focal jerking movements and acute encephalopathy. So I'm wondering if that triggers a specific illness script for you guys. Now that we've had all this updated information, we've been able to refine the problem representation to trigger one specific illness script. All right, what are your next steps? Yep. Tramadol lowers seizure threshold, imipramine. All right. Anybody? Next steps. You're not sure what you're supposed to conjure. There you go. Neurology was consulted due to concern for seizure. EEG was placed, which confirmed repetitive focal seizures, and phenytoin was initiated. The next day, the patient was alert and oriented 24 hours later. And after waking up, he did report a family history of epilepsy in his mother. Moist. Okay, again, moist. Never lets you down, okay? S. Stroke, structural, and seizures. New seizures in a 60-year-old. And exactly. That's why with the problem representation, we added all those medications in there. So how would you what's the how would you describe his seizures? What's the like diagnostic term that you would use for his seizures? CT had brain atrophy. I'm not entirely sure. It's probably just he's like chronically ill. He's like kind of, he's in a wheelchair, but he's like kind of bedbound-ish. So maybe that's just cerebral atrophy from that. All right, I'll just go ahead with this. So this would be called a focal impaired awareness seizure. Okay, and this is different from generalized because he's only having a seizure on his left arm. But he does have impaired awareness, which I think may be the reason you were thinking generalized. So generally, the classification of seizures was previously partial seizures or generalized seizures. So you get simple partial with awareness not impaired, and complex partial with awareness impaired. But actually, we're not using this anymore from what I just learned when I was looking this up. So nowadays, we have a new classification of seizure types in 2017, and you just call them focal and generalized. And then focal has aware versus impaired awareness. So his was focal because it was only his left arm, and then he had impaired awareness. And so this says that, I Googled this, Dr. Google, And focal impaired awareness seizure, this term replaces complex partial seizures. So we're no longer supposed to be using the complex and simple partial terminology anymore. What are some ways to differentiate between true seizure versus psychogenic non-epileptic seizure? This is something we review a lot. I'll just skip over it really quickly. But a true seizure is usually pretty short in duration. Their eyes are often open, whereas psychogenic, they usually close their eyes. You got the tongue biting, urinary incontinence. And then the duration of postictal confusion is much higher in a true seizure versus psychogenic non-epileptic seizure. Okay, and then what time duration of a seizure do you consider it status epilepticus? How long does that have to be before you consider it status? Greater than 5 minutes, correct. What is a complication of prolonged status? Death, yes. Hypoxia, no gain of consciousness. Yeah. Or no gain of consciousness between seizures. Yes, that's a great point, Maria. So a complication would be cortical necrosis. Basically, their brain starts to have like necrosis from prolonged status. And then what? Poor prognosis the longer in status. Yeah. What is the acute treatment of status epilepticus? Somebody's like actively seizing right in front of you right now. Benzos. Lorazepam, 0.1 milligrams per kilogram or 4 milligram fixed dose. And then you can go to UpToDate after that to figure out the doses after that. Yeah, 4 milligrams Ativan IV, exactly. What is the maintenance treatment of seizure? This is after you stopped their active seizure and now you just want to kind of maintain them a little more. Keppra, phenytoin, anti-epileptic of choice. Yep. You got phenytoin, Valpray, or Keppra. All have similar efficacy per what I read on UpToDate. What was the reason the patient was on imipramine? Do you guys know? Nerve pain. Yep, that's a TCA. Yeah, Penthouse 1's got it. So he was on it because likely for treatment of his diabetic neuropathy. Obviously, his bladder wasn't working, so I assume he had very bad peripheral neuropathy as well. Here's some indications for TCAs. One is resistant depression, and you got diabetic neuropathy, chronic pain, migraines, and OCD. And what are some of the side effects of TCAs? They've got a lot of side effects, but there was obviously one that contributed to this presentation kind of the most. But just name a few of the side effects of TCAs. Urinary retention, altered mental status, cardiac toxicity, yep. Long QTC. Yeah, and the urinary retention is part of its anticholinergic effects. Sleepiness. Anticholinergic, yep. So side effects, sexual dysfunction, antimuscarinic, sedation, weight gain, seizures, serotonin syndrome. Yeah, perfect. Kristen's got it. And torsades. And so obviously in this situation, this risk of seizures was a contributing factor. What's the mechanism by which TCAs cause potential torsades and arrhythmias? Like, what's the mechanism of action? If 8 to 10 milligrams of lorazepam doesn't break the seizure, go to another agent unless you think the seizure is from alcohol withdrawal. I like phenytoin as the next agent. 3C. Oh, I like that mnemonic. Okay, so like what do TCAs block, which ends up causing all the arrhythmias? There's a specific thing that they block. Anybody know? Yeah, sodium channel blockade. Perfect. And then what's the treatment of TCA overdose? What medication should you give them? Bicarb. Sodium bicarb to alkalinize blood. And then there's a bunch of other things you can do to support, like give supportive treatment, but sodium bicarb is definitely one of the things you want to give right away. So this is kind of for the med students, and we kind of discussed this already, but what's a type of bacteria that carbapenems are able to treat that cephalosporins can't? This is something that got pimped on at the beginning of intern year, and I don't think I got it right. But we kind of mentioned it earlier already. Yeah, ESBLs. Pseudomonas. Yeah, but I mean, cefepime can treat Pseudomonas, and ceftazidime can. So some of the cephalosporins can. Spice, that's true as well. What's the only carbapenem that can't treat Pseudomonas? Ertapenem, that's correct. And we don't really use ertapenem here. We use meropenem most of the time here. But there is one particular advantage of ertapenem. Does anybody know what the advantage of using ertapenem is? Yeah, I've really only seen meropenem here. Once per day, exactly. Once daily dosing, as opposed to meropenem, which I think we generally give Q8 hours. Ertapenem is the exception, both E's. Nice, I love it. Side effects of imipenems. Well, we kind of discussed this, but carbapenems can cause diarrhea, rash, and lowered seizure threshold, which is another of these seizure-ogenic, I'm going to call it, medications that this patient was on. And this is like a step 1 question. I don't know if anybody remembers this. Medication you can give to make a imipenem last longer. I feel like imipenem, it must be like one of the old ones that we don't really use anymore. I don't know if anybody remembers this. Cilastatin, yes. Cilastatin. It works by inhibiting renal dehydropeptidase 1. VA's got it. And then there's one carbapenem that has a decreased risk of seizures. Interestingly, apparently that's meropenem, but which this patient was on. Do carbapenems provide an anaerobic coverage? Question mark. We think so. Yes. Carbapenems provide very good anaerobic coverage. So don't ever do, well, I don't know. I don't know if don't ever do it, but ask AID. But generally don't do meropenem and metronidazole. Same thing with Zosyn and metronidazole, because Zosyn's got good anaerobic coverage as well. What's an opioid medication which can cause serotonin syndrome? Somebody mentioned this earlier. Tramadol, exactly. Tramadol works by inhibiting like the serotonin reuptake transporter and the like norepinephrine reuptake transporter. Oh, here it is. Yeah, it's a weak mu agonist, and it's a NET and a SERT inhibitor. Serious reactions with tramadol. Seizures can occur with tramadol, especially if there's concomitant use of medications that lower the seizure threshold. And so this is a medicine that's like not really super favored in terms of giving it to people with pain, because from what I learned, people have really, really variable responses to tramadol. And then obviously it's got these like scary potential adverse effects of lowering the seizure threshold. This guy was a walking risk for serotonin syndrome. Exactly. Yeah. And then here we go. Withdrawal from baclofen and gabapentin may lead to what effect? And that would be seizures. So this guy had like multiple, I mean, this is just like polypharmacy. Just basically the whole thing, just so much polypharmacy. He had so many reasons to have a seizure and other side effects from his medications. And then I just wanted to briefly go back into the subject of, discussing if this patient was septic or not. And it sounded like the consensus was he was not septic. But like I was saying, I don't think anybody would be faulting for treating him for potential infection. I mean, this guy looked so bad. So I just want to go over a brief overview of sepsis and kind of the history of sepsis. So sepsis was first described in 1992, and this was called Sepsis 1. And then in 2001, we had Sepsis 2 and this kind of landmark paper by Rivers called Early Goal-Directed Therapy. And then in 2016, we finally had an update, which was Sepsis 3. And then 2018, we had the update to Surviving Sepsis campaign. So Sepsis 1 is the first, piece of literature that introduced the SIRS criteria to us. And they also introduced the sepsis steps to us. So we got SIRS, and then you have sepsis if you have 2 of SIRS plus a confirmed or suspected infection. Severe sepsis is when you got signs of end organ damage and hypotension. And then septic shock is when you got persistent end organ damage and hypotension despite fluids. And then you got multi-organ dysfunction syndrome, which is just really, failure of 2 or more organs after that. Sepsis 2 introduced like this whole range of other signs of end organ damage, but it was just so complicated. I mean, I don't think anybody actually looks at any of this. I mean, you just like use your clinical gestalt, I guess. You don't like look up this table to like see if they fit any of these criteria. But the big problems with sepsis 1 and sepsis 2 is that SIRS is very nonspecific. I mean, any patient can become SIRS positive for any reason. Like you become SIRS positive when you're exercising. And then sepsis 2 was very cumbersome and complicated. So then they came up with sepsis 3 in 2016, where they introduced the SOFA score. And you can see this was pretty complicated too. So to actually have a better bedside assessment of people's SOFA score, they created the quick SOFA criteria, which is systolic less than 100, respiratory rate greater than 22, and altered mental status. And then for the sepsis steps, they actually removed SIRS entirely. They removed severe sepsis, and they changed sepsis definition to Q-SOFA greater than or equal to 2 plus a confirmed or suspected infection. So I've seen a lot where people are still calling things severe sepsis, but technically we're not actually supposed to be saying severe sepsis anymore. If you take a look at their paper, let's see. They said the current use of 2 or more SIRS criteria to identify sepsis was unanimously considered by the task force to be unhelpful. And then the third thing that they said, the next thing they said was the task force emphasized life-threatening organ dysfunction, blah, blah, blah. Under this terminology, severe sepsis becomes superfluous. And the task force concluded that the term severe sepsis was redundant. Okay, and then after this, I want to just briefly touch, I've been told that severe sepsis is more of a billing thing. It still has different billing code. Oh, that's something I wasn't aware of, so maybe it is. If so, I think they should update it. But I think it's also kind of a thing where people don't really follow sepsis 3. Like, people still use SIRS a lot, and people still, like, say severe sepsis. So, I feel like they should update it, but maybe it's because it's kind of been something that people haven't fully, accepted yet, even though it's been 5 years. And then I wanted to... He doesn't have anything going for sepsis because he doesn't have a single abnormal vital sign. Yeah. Yes. Thank you for that, Dr. Henderson. Can I clarify whether Q-SOFA has a role in diagnosing sepsis? Well, I'd have to look a little bit more into it because, I mean, here we have, this part where it predicts mortality. But then in this steps of sepsis, we have this thing where it aids in diagnosis too. So I don't know. The attendings might know a little bit better than me about that question. And then I wanted to briefly touch upon early goal-directed therapy. So basically, this was a whole thing where they started to give everybody a central line when they had sepsis because they wanted continuous mixed venous oxygen monitoring and CVP monitoring. And this was shown to be superior to standard care. But there were several trials, basically a decade later, which showed that early goal-directed therapy was no longer superior to standard care. So at this point in time, I don't know what it was like a decade ago or a couple decades ago. Like if everybody with sepsis was getting a central line, but that's not something that we really do anymore. Obviously, if they need a pressor, they're going to need a central line, but we don't just place a central line for like monitoring of their central venous pressure anymore. And then finally, we got the Surviving Sepsis campaign. This is just a pimp question that I got at some point. What are the 4 most important components for treating sepsis? And because we're running a little low on time, I'll probably reveal the answer. It'd be fluids, antibiotics, source control, and vasopressors. And then medical students, how much fluid are you supposed to give for someone with sepsis and hypotension? And the answer to that would be 30 cc's per kilogram, as much as they need. That's actually true, as much as they need. So generally, per the Surviving Sepsis campaign, 30 cc's per kilogram. But I did recently read this paper which showed that the evidence for blindly giving 30 cc's per kilogram is actually very poorly evidence-based and more just like expert opinion. But there's actually there's some evidence that shows that blindly giving 30 cc's per kilogram is actually detrimental in a lot of cases, but it's still kind of what we do based on the Surviving Sepsis campaign. Agree totally. Another clinical decision. Yeah. So, the Surviving Sepsis campaign in 2018, prior to 2018, they had this 3-hour bundle and a 6-hour bundle where you measure their lactate, get blood cultures, give antibiotics, and give 30 cc's per kilogram. In 2018, they combined it all into a 1-hour bundle where you do the same things, but basically they just simplified it all, so it's in a 1-hour bundle. And here's some signs of adequate resuscitation. Their MAP should be getting better. Urine output should be getting better. Mental status and lactate should be getting better. All right, and then that's basically it. So my take-home points. First, we went over, why we do problem representations. They're an important exercise in clinical reasoning. The goal is to propose illness scripts and refine our pattern recognition and develop type 1 thinking. And remember to keep the problem representation simple and adjust it as new data is collected. And then we briefly discussed the age cutoff for defining elderly, maybe increasing, and really should be individualized for each patient. Don't miss the important treatments before working up altered mental status. Again, that's dextrose, oxygen, Narcan, and thiamine. Moist is definitely the best mnemonic for causes of altered mental status, in my opinion. But it's just so much shorter, and like the other ones are just too long. I can't remember all what every letter stands for. So I would highly consider picking up this mnemonic. In an altered patient with significant polypharmacy, consider lowered seizure threshold as an etiology of their encephalopathy. And this is another important reason why we need to reduce pill burden in our elderly population. We reviewed the diagnosis and treatment of seizure and also the side effects of some of the medications he was on, like imipramine, meropenem, and tramadol. And then per Sepsis 3, the terms SIRS and severe sepsis are outdated and should not be used. QSOFA should be used instead, but I leave this up to your discretion, especially with this whole billing issue that I was not aware about. So that's it. That's everything I have. We should compromise and call it MISTO. Yeah, you could just call it MIST. They put oxygen under the metabolic causes. Hospitals haven't fully adopted Sepsis 3 based on the 1-hour bundle. EM groups oppose this timeline. Bundles have the unintended consequence of blunting your clinical thinking and reasoning. Yes. Thank you, Dr. Henderson.
Great case, Conan.
Awesome.
Thank you.
Yeah, thank you guys.
That was awesome.
Thank you. Bye-bye.
All right, bye-bye.
Thanks for doing it from Boston too.
Yeah.
Great job, Conan.
Yeah.
That's amazing.
Thanks for tuning in, you guys.
Bye.